you for the opportunity, and I try to be as brisk as whatever does. So this meta-analysis was undertaken because obviously there is no randomized phase 3 data to say there is an ethnic predisposition to development of pneumonitis. So this meta-analysis was published. This comes from China. This was across 4 hospitals in Wuhan. It was published in September 2023, and we all know what led to this. So basically, in stage 3 patients, which constitute about 1/3 of the NSCLC patients who come to us, concurrent chemotherapy was the historical standard of care, but with specific data, now we all know it has to be followed by nivolumab maintenance. But then it has been found that there is increased lung-related toxicity. Radiation pneumonitis is a common side effect which affects the quality of life, and it could depend on many factors which could predispose and increase the risk of radiation pneumonitis. The subgroup analysis of Pacific pointed that patients are way more predisposed to develop pneumonitis. There is also a meta-analysis available hinting towards the same. So this meta-analysis tried to study whether there is any whether this actually exists. So all the records from over the 23 years were pulled out, and they tried to include those studies which are more conforming to the current standard of care, and they tried to exclude all the confounding factors. So obviously they tried to include more prospective data, the ones which were using 3D CRT or IMRT technique, and patient studies which actually reported the rates of pneumonitis. They tried to exclude all those studies which were using the older forms of radiation and anything that is not the standard of care, like gemcitabine-based regimens using cetuximab, endostatin during the radiation therapy, and anything which, any of those studies which did not report the rate of pneumonitis. Right, so they tried to extract all the details, that is obviously the baseline characteristics. Apart from that, they looked at the RT technique, the RT dose that was given, what was the chemo regimen used, what was the V20, that is the mean volume of the lung receiving more than 20 gray, the mean lung dose, and of the incidence rates of pneumonitis. So they also tried to look at subgroup analysis within the meta-analysis. They tried to see if prospective studies had anything different to say, or patients who received IFI, involved field radiation, rather than elective nodal radiation, was this contributing to any difference? So after screening through lots of articles, that is 11,000 articles through the 23 years, they finally came down to 248 studies after the inclusion and the exclusion criteria. Of these 248 studies, 174 studies come from a time where patients received definitive CRT only without immunotherapy. 64 studies looked at CRT with immunotherapy, and 10 studies looked at both the populations. And most of the patients had received concurrent chemoradiation therapy and with platinum doublet as the chemotherapy regimen. Baseline characteristics were matched in all these studies between the Asians and the non-Asians, excepting that in the Asian studies they found that the males were outnumbered, and never smokers also outnumbered. The most common IO was durvalumab. There is obviously, when you're trying to conduct such a large meta-analysis, it's obviously bound to have a lot of confounding factors, a lot of bias. However, they came up with these results. That is, in those studies which looked at CRT without immunotherapy, there was higher prevalence of pneumonitis in the Asians when compared to non-Asians. All-grade toxicity 68.8% in Asians versus 28.1%. And as you can see, irrespective of the grade, the prevalence was more in the Asians when compared to the non-Asians. Even in the subgroup analysis across, like prospective, whether it's prospective studies, retrospective studies, patients receiving CRT, even with IFI, all these subgroups also had more predominance of pneumonitis. In the patients who received CRT with immunotherapy, all grade toxicity was higher in the Asians and grade 2 toxicity was higher. But as you move to higher grade toxicity, there was not much difference. Like grade 3 and grade 5 toxicities were pretty much similar between the Asians and the non-Asians. So this is despite the fact that the V20 was higher in the Asians, and the mean lung dose was also higher in the Asians. Now, what could this be due to? This could either be due to the, the genetic makeup could be different. EGFR mutation is more predominant in Asians. Maybe this is contributing to, increased risk of pneumonitis. And like that table I was trying to show, despite the lower doses V20 and MLDs, maybe the Asians after all have poor tolerance to radiation for their lungs. Or it could be because of the different choices of the IOs that were made across. Now this meta-analysis has a lot of limitations. It is obviously there's no real randomized control trials. There's significant heterogeneity among the studies, or different studies use different criteria for reporting their pneumonitis. Baseline IIT was not reported, and different studies had different endpoints. So the meta-analysis concluded that Asians are more likely to have a higher incidence of pneumonitis than the non-Asians when treated with CRT with or without immunotherapy. And the prospective larger studies are required for this. Now, I don't know, maybe this is too controversial to say, but maybe Asians might require a different dose when compared to the non-Asians, and maybe we need to optimize our therapies when treating Asian patients. Yeah, thank you.